Okay. Professor Davies is an associate professor of occupational and environmental health at the University of British Columbia. He has a PhD and a Master's of Science in occupational and environmental hygiene and is certified by the American Board of Industrial Hygiene. He is also an adjunct professor at the University of Waterloo, an honorary professor at the Bangladesh University of Health Sciences, and an affiliated scientist with the Occupational Cancer Research Centre in Toronto. Professor Davies' research examines chemical and physical hazards in the workplace and in the community and their effects on human health. His work has included studies of occupational exposures to antineoplastic drugs in hospitals, wood dust and bioaerosols in wood processing, and respirable crystalline silica in construction. His work also includes examining the role of environmental pollutants in chronic disease. Professor Davies teaches occupational health, exposure assessment, epidemiology, and research development in the UBC School of Population and Public Health. He is a member of the ACGIH TLV Committee and the past president of the Canadian Association for Research on Work and Health. Please join me in welcoming Dr. Davies.
Thanks, Noel. When I gave you that, I thought it was just going to be in print. I didn't realize you were going to read the whole thing. This seems really, really loud in here. Is it? I'm barely whispering. Yeah. Can I turn it down a tiny bit? How's that? Okay. Okay. So yeah, thank you for that intro, and thanks for inviting me to speak today. I'm going to be talking about a project that is actually ongoing. It's a work in progress, and there's a number of other people involved whose names aren't up here, but I definitely recognize them as we go on through the talk. It's a bit unusual to be talking about a work in progress, but because this is a surveillance project, we are giving feedback to the hospital sites involved all the time, and so I'm able now to give you some of the interim results. But before I do that, I'm going to talk a little bit about the background of the problem, why we're doing this study, and then the study design itself, and then talk about where it's headed in the future. So, starting with the problem at hand, antineoplastic drugs, very widely used. I mean, you're probably all very familiar with this term. Sometimes they're called cytotoxic drugs or chemotherapeutic drugs, very widely used in the treatment of cancer. They're inherently toxic. The whole purpose of these drugs is to prevent, inhibit, or in some way stop the growth of tumor cells, and thereby the tumor themselves. And so they act typically by inhibiting some part of the cell cycle, either the DNA replication phase or mitosis, or some other part of which causes cell destruction or without necessarily interrupting the cell cycle. But they're all inherently toxic. And they're not all necessarily used for cancer treatment only, but also in other diseases such as rheumatoid arthritis and multiple sclerosis, where they have proven therapeutic effect. So because of that, that toxicity, it's not surprising that inadvertent exposure to these drugs is also associated with a number of adverse health effects. Carcinogenicity, teratogenicity, reproductive toxicity, such as spontaneous abortion, malformations, genotoxicity, and organ toxicity, even at low doses. And as with many occupational exposures, they differ from the exposures that the patients are having, which may be higher level for shorter periods, in that they can be chronic, go on for months, years, even decades, and they can be complex mixtures. So as you'll see, we're looking at potential exposures to multiple drugs simultaneously in the workplace. What's the scale of the problem? Well, one way of looking at it is how many people are likely exposed to antineoplastic drugs in the workplace. And in Canada, this is estimates from CAREX Canada, the Carcinogen Exposure Surveillance Project. that thinks that about 75,000 Canadians are exposed. About 75% of those are female because of the nature of the distribution of sex in these occupations. And not surprisingly, the majority of those are in pharmaceutical occupations, pharmaceutical technicians that do a lot of the drug preparation work, pharmacists themselves, and then clinical staff like nurses who are responsible for the administration of the drugs, and then others that might have indirect exposures, such as cleaning workers and laundry workers. And then there are other health professions, such as veterinarians and veterinary assistants that may be exposed, as there is increasing use of these chemotoxic drugs in animal care, small animal care. Another way of looking at it, and this is something which has been reported many times and is troubling from an aspect of potential exposure in the future, is that although we see a decrease in cancer incidence overall, or incidence rates, which are shown in those blue lines, this is from Canadian Cancer Society statistics, you can see a reduction in the annual standardized incident rates in both sexes. What you also see is actually an increase in the number of new cases, and that's being driven by demographic changes because we've got an increasing population, an aging population, and so that means that we're going to see very dramatic increases in the number of cases that need to be treated, the number of people going to hospital to receive chemotherapeutics, and therefore the potential for exposure by workers is going to also increase. So getting a bit more detailed, this mic is cutting out, isn't it, a bit?
No, online it's fine.
Oh, it's in here? Okay. So getting down to a more detailed look at the exposure potential, this is a schematic from Chun-Yip Hon's work, also done here at UBC, that just sort of shows the process flow, if you like, of drugs through a treatment center. It's pretty clear that we start with drugs being delivered to the pharmacy area of the hospital, and when they arrive, they're going to come in a cardboard box, has to be unpacked. This shows a typical receiving area where that work will be done. And then they are moved into some kind of storage. In this case, this is a cold storage fridge, 4-degree fridge, but it could also be room temperature storage. From there, the drugs go on to be processed. So the drugs are prepared for the administration to a patient. So this could involve setting up an IV bag. It could involve reconstituting dry drugs that are in powder form, diluting drugs. This is usually done in a clean area and in a biosafety cabinet. From there, they then are transported in some ways. There's a lot of transport involved in these drugs between reception, storage, prep area, to the ward and so on. So this actually shows a thing which is common to most of these centres, which is a pass-through from the clean area to the non-sterile area. It's like a little airlock. And the drugs would be placed in a tray. So trays or bins are also commonly used. And then into a cart, and there's another kind of bin, which would be, could contain IV bags or syringes or other forms of administration. And then they go into the clinical area, which may be a daycare area. So this would be where people come in for to receive their chemotherapy, and they may be there for a few hours, but they will leave by the end of the day. Or it could be an inpatient ward if the treatments are being given to patients that are staying overnight or longer. This shows a typical side table, again, where a bin might be placed, or an IV bag, or some supplementary equipment. And then a lot of these drugs are given by IV, so this is an IV pump, which again may contact or have contact with vials or containers containing drugs. There's a whole disposal process which is quite standardized in the sites we're looking at, or many of them. They use these standardized bins for cytotoxic drugs, and then they go off to waste retrieval. But I'm also showing here that there are other aspects of the environment that we're interested in, and one area that has received a lot of attention in the past, and we're also looking at it, are toilets. So these are where patients would go during the day if they need a toilet. So anywhere that could be touched in these areas, such as the toilet handle itself or the door handle, are all of interest in terms of looking for potential contamination. In terms of the tasks that generate exposure risks, just briefly I've mentioned some, but even the receiving operations, there's evidence that some of the incoming drugs, the vials in which they are contained, can be contaminated from the manufacturing process. But you could also imagine that sometimes there's damage to those vials or containers, so that they're maybe actually broken and leaking. Drug preparation includes many different tasks in which toxic drugs can be spilled or vaporized, aerosolized, etc. And the patient care side of things, there's the actual administration of the drugs, the priming of an IV set where there's potential for spills, and then the handling of contaminated dressings, linens, and other wastes. And then in both scenarios, once contamination has occurred, there is a potential for cross-contamination as objects are moved or people touch one object and then another object. So that sort of outlines the problem. In terms of how it's been handled in terms of policy and procedures, I want to thank one of my colleagues, Hannah Kaup, University of Minnesota, who produced this slide, and I think it really encapsulates it well. So the first concerns about occupational exposures really happened in the 1970s, which was about 30 years after they had begun use in the hospital setting. It was another 10 years before the first studies were done, which showed that this potential was actually real, and that these early studies were looking at mutagenicity of urine. So it showed that actually healthcare workers had sufficient antineoplastic drug residues in their urine, that their urine was mutagenic. And then that led to the development of guidelines, revised guidelines, and so on until we get to the point we are today, where there's a lot of emphasis on, or a lot of reliance on guidelines such as NIOSH's 2004 alert and the USP, or the US Pharmacopoeia Chapter 800, which is in the process of being implemented now. BC has regulation and guidelines specific to antineoplastic drugs. This is one of the documents that they produced. However, it's undergoing review and unlikely to be reviewed or available, in its reviewed form until 2020. In terms of specifics, certainly hygiene students here will not see anything here that I imagine they're surprised about. So we got hazard assessment. This is how the NIOSH outlines it: hazard assessment, safe drug handling, and then proper use and maintenance of equipment. And safe drug handling is really what we're going to see in our hospital care settings, and we see proper labeling of drugs and equipment, at proper storage. The use of PPE is very important. There are chemotherapy-specific gloves and gowns. I mentioned the use of biosafety cabinets with specified type 2, negative pressure environments. Something which is unique to this type of problem is the closed system for drug transfer. So there are various systems on the market, That picture on the right shows one in use. These essentially allow for the transfer of a drug from one vial or container to another, in this case from a syringe to an IV bag, with no possibility of a leak or of either liquid or gas. So these have great promise and well, certainly something we're looking at in this study. Sealed bags for transport, and then of course relevant and effective cleaning protocols and protocols for spill control. However, with all these things in place, contamination still appears to be happening and quite prevalent. So France Lebrèche, who some of you will know as a co-author on a study that was released this year in Quebec, where they've looked at 7 years of data since 2010 across a number of hospitals across the country, and they still find contamination levels are pretty consistent. So from year to year, they're not seeing, in terms of the number of contaminated sites, a big or any reduction at all. So contamination is still a problem. Wasn't sure where to put this slide, so I put it in here. But I wanted to point out, and I did say I've mentioned that I have many colleagues in this. In fact, I'm probably, although I'm the PI, I'm probably the most junior person in this team in many ways, because I'm the last one to come to this party. But work, as early as I could put it, was here at UBC, began in around 2010 with Kay Teschke, John Spinelli, and Pam Ratner, who did a very nice study on a cohort study looking at breast cancer on BC nurses. And then Chris Barzan, who's a graduate student now, OHO at WorkSafe, was looking at cleaning byproducts. So what happens when you clean something, a cytotoxic drug? What are the byproducts? Chun Yip Han, who now is at Ryerson, did his PhD thesis in this area. And then perhaps most importantly, the work that I'm talking about today is really follows from the work of Matty and Manuel, who many of you will know in our lab, who've developed this greatly improved wipe sampling method for surface contamination analysis, and by George, who's here today, who's been the PI or a very important contributor to many of these studies and has a long history of work in occupational health and safety in the healthcare sector. And the people that aren't on here, and I must mention now in case I won't forget, but I'll mention now, is Susan Arnold, who's our University of Minnesota collaborator, and her PhD student, Hannah Kaup, who have also been working in this area, and I'll specifically mention Hannah's work again a little later on. So anyway, as I say, this study is a natural progression of a long line of studies here at UBC. Okay, so the issues at hand then were, despite these control measures, we still see antineoplastic drug contamination as a problem in healthcare settings. Healthcare workers are being exposed to these drugs, and that doesn't seem to be currently under control from the work of people like France Lebrèche. There are new regulatory guidelines, regulations and guidelines, and some of these, like the USP 800, have specific requirements for surveillance of contamination, but they're very short on detail about how to do that. So that's an area where there's a gap. There's a lack of standard methods and strategies on how to do surveillance and techniques to use. There's a lack of data. If you do a search, a lit search in this area, you'll certainly find lots of studies around the world that are looking at contamination levels and determinants of exposure and some of the things I've been talking about. But actually, when you get down to the health region level or the hospital level, and certainly amongst the agencies that we are working with, there's very small amounts of data. So not all the hospitals are doing any kind of surveillance. Those that are maybe only looking at one drug, and maybe only once a year on a limited number of locations in the hospital. There are no occupational exposure limits for any of these antineoplastic drugs, no TLVs, no surface wipe limits, although that's a new concept that the ACGH TLV committee is adopting and recommending in the notice of intended changes. There's going to be, we hope, or we've proposed a new kind of OEL, but the initial two, at least, that have been proposed, and neither of them are antineoplastic drugs. Another issue is the cost. So where we do have methods, very expensive. So this is a barrier to use in the healthcare sector, I'm sure. If you go again and Google what's currently available commercially, they start at about $160 US per drug per sample. As I'm going to talk about our project where we're looking at 11 drugs at a time, you can see that the costs, at least commercially now, are prohibitive for any kind of comprehensive surveillance system. And then technically there are many issues. One that's raised itself repeatedly during our initial few months of this study is optimizing cleaning procedures. When you know you've got a contaminated surface, how to clean it, and how to know that it's been cleaned properly. And by cleaning, I mean removal completely of the hazardous substance. So, given all that background and those issues, we decided that we would apply for a grant to, as I say, further the work that had been done here, particularly the development of our wipe sampling method by Maddie and George and Manuel, to really try and get a better understanding of the temporal and spatial distribution of contaminated sites. And so surfaces is the study. I'm actually very proud of this. This is the first time I've ever come up with an acronym that actually sounds kind of cool and actually means something. It's never happened before. So kind of like saying surfaces. So the objectives of the study is to basically do a thorough characterization of surface contamination. We were really pleased that we could get two different jurisdictions involved. I mean, two completely different healthcare systems, right? A US system and a Canadian system. We wanted to look at what kinds of factors influence the variability of contamination by antineoplastic drugs, and then how that varies over time and space. So I say a lot of the studies that are done are one-shot deals. They just are very cross-sectional in nature, I should say. And then what we're hoping to do is we can use this information to make recommendations around the detailed implementation of these new surveillance regulations or requirements. So this is a concern for those people that are having to implement, for instance, USP 800 it's all very well to say you have to do surveillance every 6 months, but what does that actually mean? Okay, so I'm going to talk a little bit about the study design. So surfaces, we have 9 sites, 6 in Alberta and 3 in Minnesota. We also selected sites based on size, so that we have that as a variable in our modeling. So you can see that bottom line of the table. The large centers are approximately, this is the number of IV doses per month, anywhere from 2,000 to 4,000, going down to a small community center, which may only have, say, 1 or 2 beds, as low as just a few dozen IV doses a month. We're looking at both pharmacy and clinical areas, mostly daycare, but in each of the 2 areas, Alberta and Minnesota, we're also including 1 inpatient ward. The study is a full 12 months, and at the approximate study design, or the rough study design, is that every one of those 9 centres is essentially getting sampled monthly. They all have sort of rest months, and we do too here, so it actually works out to about 8 months of the 12. They're randomly assigned, and then within each sampling campaign, I've called that, so each month at each site, there are approximately 20 locations in the facility in pharmacy and clinical that are being wiped, or getting a sample wipe done. And then embedded within that, each site will participate at least once in what we call an oversampling month, where instead of just having one set of wipe samples done, they'll be repeated either over a day or 2 days, that's what I've called temporal oversampling, or spatially, which is where we take multiple samples of the same surface. So as you'll see, a wipe sample of a surface usually is just a small piece of the surface, a small, can't keep using the word sample, a small representative part of the surface. But we want to see if by taking multiple samples over, say, a countertop or a biosafety cabinet, stainless steel tray, what's the variability within one surface? We very quickly developed a really good rapport with the centres. This has been crucial to this kind of study. And so the folks at Alberta Health Services and Fairview Health Services, who are our participating centres, have been outstanding in their cooperation. We have a technical advisory committee that meets monthly, and from Alberta Health Services we have representatives of oncology, clinical and occupational health and safety, as well as the staff from here and the investigators. And that communication has been, as I say, crucial to the success of this project, and been extremely valuable in making sure that information flows quickly, which it has to in this nature of a project where we find information about a contaminated surface and we want to get it back to them as quickly as possible. They report, at least in Alberta, they're reporting back to the Alberta Health Services Systemic Therapy Council, which oversees the use of chemotherapeutics throughout the province. We also instituted a user forum, so as you'll see when I talk about the methods, the actual wipe sampling is done by staff at the hospital. We don't have our research staff go out and do it, but rather nurses or pharmacists or pharmacy technicians do the sampling. And so once a month, up until now at least, we've had all of them and all the deputies, so often about 20 people or more, have a phone meeting, which has been a very, we call it the user forum. Basically it's open to any questions or concerns, and so we shared tips and techniques, and that I think has been very important in keeping up the quality of the and the validity of the sampling that's being done on the sites. Okay, the drugs that we're looking at, I won't spend a lot of time here, but there's 11 of them. There were 10 in the work that, or the work that Maddie did, basically created a method which had a base of 10. One of those we dropped because it's not used in Alberta or Minnesota, Vindicine, but we added two, bortezomib and gemcitabine, which are very, or more widely used in both centres. And so part of this study was additional method development by Natty and Andrew, who basically got the analytical technique up and running for those and validated in very quick time, and that went very well. And then, as you can see, there's some hazard information, and basically all of these are listed as by NIOSH as hazardous, and many of them have been reviewed by IARC and have an IARC classification anywhere from 1 to 3. I think I'll just skip that. That's basically detailed analytical information about the LOD and recovery and desorption, and as I say, this has been work that Maddie and Andrew have been doing. But essentially, this was reported out in a presentation here, actually, at a seminar a few years ago. Okay, so what are the sampling locations within the facilities? That right-hand column should have a title that says clinical. Don't know what happened to that. But to select these sampling locations, every single site was visited by a member of the research team, either me or Matty or Susan, and we talked to the pharmacists and the nurses, and we chose these based on not the likelihood of contamination, because that's easy to find things that we expect to be contaminated, but really that followed that process flow that I showed you through the entire facility. They're sites that are likely to be handled or touched by people, and they had to be common amongst all 9 sites so that we could do cross comparisons. There are some additional sites that I haven't put on here for the inpatient wards. The surface wipe sampling itself, as I say, they're user administered. So essentially all we do here is all we do, it's still a huge amount of work, is build a kit which is shipped out by courier. It's temperature stable, and it contains things like the vials here, which are pre-moistened. There's a solvent in there with the wipes that the users are actually going to use to sample the surface. Templates, so we're aiming for 100 square centimeters or 10 by 10 square. These are disposable so that we're trying to avoid cross-contamination. Various paperwork, chain of custody forms, supplementary data forms, which describe what was happening in the clinic or the pharmacy that day, and then a collection of assorted tools like forceps, rulers, and tape. And I had gloves on here, but when we asked them if they needed their gloves, they said, well, we have lots of gloves. The one thing we do not need here is more gloves, so please do not send us any gloves. And again, this has been reported here before, but essentially the surface wipe is no training is needed, although there is a YouTube video available. There are instructions on one sheet of paper, and Maddie's group has done the validation work that shows that there's sufficient inter-individual or limited enough inter-individual variability that you can use this in this manner. We have different people taking different samples and still get valid results. But it is very simple. The wipe is taken out of a vial, and the 100 square centimeters is wiped in both directions, and then the wipe is returned to the vial, and the whole thing is shipped back to us. And as I said, even in this state, it's still temperature stable for several days, and so we don't have to really worry about cooling, although we do provide a cooling bag to try and limit any real excursions in temperature. We also went to a great deal of trouble to ensure that the shipping was really smooth and that bags or boxes didn't get stuck out on a loading dock for a weekend and so on. So we've got some safeguards in to make sure that the transport of these back and forth is as quickly as possible. And then, yes, they come here for laboratory analysis by Maddie and Andrew. It's a liquid chromatography mass spec process. And here I go right here. So Maddie actually gave a seminar on it just 3 years ago already. Wow. But that's available online. So if you're more interested in the specifics of this technique, then you can certainly go back and watch that seminar. Okay, so I have some results just so that you can see what the kind of data this is producing. So we've been through 4 months completed. We actually just finished the 5th month, but not in time for me to sort of add that data to these slides. And so during those 4 months, we completed 28 campaigns. So 28 hospital sampling campaigns at the 9 sites. So all 9 sites have had at least one. Most have had 3 or 4. That resulted in 633 vials or samples coming back, so 633 locations around those 9 sites over 4 months. And because each one gives us 11 drug measurements, that's a total of almost 7,000 observations. And here I'm going to be reporting just sort of very aggregated and summary data, but the individual data, as you'll see, goes back to the hospital sites. First of all, not every site we have looked at, or every sampling location has been contaminated or by drugs, but in all, 7.4% were found to have some detectable level of drug residue on them. The actual amount, so all 11 drugs are shown in this table. You can see depending on the drug, that level, that's the number, the total percentage of sites contaminated varies from virtually none, 0, up to 30% of surfaces. Okay, so gemcitabine, which was one of the ones we added in at the request of the sites, was detectable at least on 30% of the samples that we received. Paclitaxel 13, cyclophosphamide 12, ifosfamide 6. Now because these are interim results, obviously we're waiting for 12 months of data to do their full analyses, but thinking about why these may vary so much, the first thing that, of course, that comes to mind is, well, how much of the drug was actually being used? Because if they're not using very much oxaliplatin, then you wouldn't expect to find much contamination. And that's probably the major driver here. Gemcitabine, paclitaxel, cyclophosphamide, ifosfamide are all in the group of the more heavily used drugs in these centers. But there are other sort of subtleties. One is persistence on a surface. So all of these are completely different chemicals, and they react in physical and chemical ways differently to surfaces. So some, like paclitaxel, tend to persist on surfaces for long periods of time. Others, like vincristine and vinblastin, don't seem to persist for very long at all. And so even if there are contaminated sites, if we're not sampling right away, we may not be finding them. And the other thing is recovery. Different surfaces tend to hold on to different chemicals in variable ways, and so we're not necessarily getting 100% recovery of all these drugs on all surfaces. So there are various things that may influence these numbers. In terms of what is being contaminated, I hope this doesn't look too bad. I know sometimes the colors that people see on here are totally different, but that's actually, I think it's even readable. Okay, so what this shows is the percent of samples above the limit of detection. So all this is that these drugs, these surfaces had some drug, it can be any one of the 11, detectable this percent of the time. So in other words, the BSC is the biosafety cabinet. 1/5 or 21% of those samples had some detectable level of drug contamination. So that's not at all a surprise, because that is where a lot of all the drugs pretty much are going through there, and they're being manipulated in some way, reconstituted, diluted, etc. And that's why the work is being done in a biosafety cabinet, because of the risk of exposure. But surfaces like the cart, which is part of the transportation system, or the fridge door handle, which is just a storage area, chemo bin, part of this transportation sort of system, and then room temperature storage. These are all areas which are less, there's less obvious what the determinants there are, other than throughput. But you can see that the majority of the higher contaminated areas are in the pharmacy, or areas which are contacted by both pharmacy and clinical staff. And once you get into the clinical area, the highest contaminated areas appear to be the washroom door handle and the toilet handle itself, the flush handle. So this is yeah, I mean, some of these things are, as I say, not surprising, but others are interesting and definitely sort of areas that we'll be looking into once we have a full data set. Okay, in terms of where the highest levels of contamination, so that's the most contaminated, but where do we find the highest levels? And this is difficult to get down to one table because we've got 11 drugs, and I didn't want to have a lot of sort of numbers on a table. But combining those two things, frequency of contamination and the level of contamination, the most contaminated would, under those definitions, be the fridge door handle, followed by the washroom toilet handle. In fact, both of those, in every single sample we've taken of those two sites, we found contamination by at least one drug. In terms of the levels of contamination, so I've got a few of these box and whisker plots to show you. I'll just maybe focus on this page. This is the top 4 in terms of the number of samples that we obtained that are above the limit of detection. So gemcitabine with 208 samples above the limit of detection. So what's this showing us? Well, first of all, again, these are the most used drugs, so we're not surprised that they're the highest in terms of the number above the limit of detection. But perhaps what's really interesting here is that just the range of exposures, which varies over several orders of magnitude. So that's good for our study because obviously we want to look at variability and we want to understand where the variability comes from. So certainly for several of these drugs, we have, again, from the analytical perspective, it's pleasing that we have plenty of data and that it has a large degree of variability. Across all of these, it's fair to say, I haven't shown it here, that levels in the pharmacy area were higher than levels in the clinical area, which again might be expected because of the volumes of drugs that are used there and the way in which, or perhaps more importantly, the way in which they're being used there. What else can I say about this? Well, again, for the hygiene students, I hope you recognize these are all right skewed, very nicely log normal. So that's a log scale on the left hand, on the y-axis. Something else that we've started to know, it's very early days yet, but it is. And one of the advantages of the study design is temporal trends. So one of the things we're interested in is what happens with time. And certainly, as well as these differences between chemicals and between sites, we're also starting to see what we think may be temporal patterns, and temporal variability, which is, it's too early to really talk about yet, but it's exciting for future analysis. Just got a couple of last slides here about how we're reporting this data back to the center, so the surveillance part of this. So very early on, the Technical Advisory Committee had a lot of discussions about how this information should be passed back. All the sites involved did not have an ongoing surveillance. Some of them had done a little bit of work in this area. And in fact, one of our partners had published has published their work, but nothing on this scale. And so we came up with a reporting method. So each site gets this kind of report. This is just a part of one report for 1 month for one site. You can see there's a huge number of data. What we show is the sampling location, the size of the sample, and then the exposure level for each drug. This just shows 6 of the 11, so there's another page showing the other 5. And what we've done here is to attract attention and to make sure there are no, or reduce the number of misreading errors, is anything above the limit of detection is shown in blue. And then anything above 1 nanogram per square centimeter is highlighted. And so the centers can then use this data to initiate whatever processes they wish. This is not an intervention study, so we're not asking that the centers do anything different than they already do. And that can change during the 12 months. So to deal with that aspect of the design, we are actually then having them feed information back to us about cleaning protocols and so on that we can put into our final models. Now, I've been talking about limits of detection, but as you are aware, limited detection is somewhat arbitrary. It's based on the technology we're using to do the analysis, in this case LC mass spec. But if someone used a different technique, they would have a different LOD. So the LOD itself is of limited use. And so the question is, well, what does it matter if it's above the LOD or below the LOD? All you're saying is it's detectable. And what does that mean in practical terms? Well, as I said, there's no TLV for any of these drugs. There's no surface weight limits. What there are these things called hygiene guidance values. These have been reported by several researchers, but essentially they're a statistical indicator, so they're based on probability. People usually pick the 95th percentile of all observations, or sometimes the 75th percentile, and they set that as a target level to achieve the next time you sample. Okay, so it's based on the what was achieved at a certain point in time at that site, and by lowering the target, essentially it's a form of an OLARA intervention, because every year you're trying to reduce your samples or your contamination to below, in this case, the 95th percentile, but it could be the 75th percentile. So it's an intervention which has long-term merit in terms of reducing overall levels. Because of the vast number of data we were producing and the different sites involved, different regions, the Technical Advisory Committee wanted to take a different approach. They ideally wanted a health-based limit. Well, that's eluded many people for many years. It's tricky to do that, and also to come up with one that's appropriate to surface wipes. And so what we did was we took a first cut at this kind of idea, and this was work largely done by Susan Arnold down in Minnesota. And what she did was she actually did dig down, and although it's not public OEL, or I shouldn't say that, not OELs published by regulatory bodies or at ACGIH and so on, many pharmaceutical companies have internal OELs. And so for a number of drugs, she was able to obtain these. And then we used a method which is commonly used in toxicology and risk assessment, is we took the OEL, which is an 8-hour inhalable limit, and we just multiplied that by how much air the average adult breathes in a day, which is about 10 cubic meters, and that gives you a mass. And we assume that mass was a sort of no observable effect level dose. And then we simply divided that by our 100 centimeter square template. Now that in itself is hugely arbitrary. It's sort of basically saying that it's assuming that if a person puts their hand on a contaminated surface, they suck up whatever's on that surface, and that it shouldn't exceed their daily dose in that sort of instant. So this is full of assumptions and limitations, but at least it's a sort of step in the right direction towards health-based. And what was pleasing about this is that when we did that, we came up with these wipe limits, which are in the right-hand column, and cyclophosphamide, the number 1 came up, and that is actually not surprising, because that is the only one where there is sort of a health-based logic. I won't go into it now, but everything else was higher than that. So we said, well, let's just set everything in an abundance of caution to 1, And in doing so, we've got a safety factor of at least 10 for ifosfamide and more likely up to 100 for these others. So all that one says is we're not saying this is a safe level. We're using that as a trigger for our sites to initiate a cleaning protocol. Okay, so moving forward, well, as I say, it's a work in progress. We have another 7 months of data collection to go. We're really sort of starting to ramp up our oversampling, which I think is going to be really interesting. So that's looking at sort of short-term temporal and spatial and small-scale temporal and spatial variability. We're thinking about adding additional sites. Matty and Andrew are doing such a marvelous job that we have excess capacity in the lab. So we're thinking about recruiting additional sites into the study, or actually just collecting previously existing data from some sites that are able to offer it. We've also started to put together some cleaning efficacy studies. So one of the many challenges we had with this study so far is people think they're cleaning things and it doesn't look like it's actually working. So, for example, one site we had where they did a pre-cleaning and a post-cleaning sample, and there was actually more contamination after the cleaning than there was before. So we're starting to do some studies to look at why that might have happened. And then I mentioned Hannah earlier. So Hannah's a PhD student at the University of Minnesota. She's doing some really interesting work around behavior, the behavioral aspects of the employees, about how often they touch surfaces and for how long they touch surfaces and the order in which they're touched. And she's just published her master's thesis on this. And we think it would be something that we can include in our ongoing work in Alberta, particularly sort of transfer it up here, because we're already starting to see big differences between some sites, and we think some of those may have to do with behavioral aspects that we'd like to understand better. Data analysis is with a thinnest slide, because we're, as I say, in the process of data collection, but we are starting to merge our supplementary data. I mentioned that none of the data I showed you was adjusted for drug volumes, for instance, in use, or patient numbers, but we have all that. We're starting to include that, as well as all the other deterministic or sort of determinative exposure kind of variables. The use of those closed drug system transfer devices, we have information on that, so not all the sites use them, so we'll be able to include that. Time, I mentioned, appears to be an interesting determinant, and we'll be including time in various ways, I'm sure. So we're building that data set right now, and that will go into some pretty traditional determinants of exposure analysis. The second major objective, developing recommendations for monitoring strategies, is an interesting area, and I think one that is going to be very exciting to sort of delve into. So, as I said, the USP 800 and other guidelines say, well, surveillance must be done every 6 months. But what does that actually mean? Like, it doesn't say what the objective of the surveillance is. So clearly it would be nice to have a system where you could just wipe a surface and say, is that contaminated? And then clean it and say, have I cleaned it? The current technology which we're using doesn't allow that. It takes a week or more to get your data back from the lab, and it costs hundreds of dollars. There is technology, sort of direct read technology in the works. There's at least 1 or 2 papers that have examined immunochemical monitoring methods which have promised to do real-time assessment. But the kind of work we're doing is probably going to be more useful in terms of long-term surveillance, so in terms of looking for trends in exposure, like those hygiene guidance values do, or sort of more audit style, where you can focus in on a center and look for areas that are contaminated, and then look at the behaviors or processes in place that may be improved to reduce contamination. And there's probably many other kinds of uses that I haven't articulated. In terms of the kinds of analyses that we'll be using there, we're certainly going to have a very rich data set in terms of spatial and temporal variability. And I think what we'll be looking for is obviously predictive capability of various determinants, but also which are the key indicators. So if we're able to tell a center at the end of this that some drugs, for instance, are not even worth looking for because they don't persist, you're never going to find them. So which drugs to look for, which are the indicator sites? Maybe some sites are like the canary in the coal mine. You know, if you find it there, you need to look further. If you don't find it there, you're probably safe. So there's all sorts of little avenues that I think are going to be exciting to think about when it comes to that stage of the analysis. There's always more future research probabilities. I'm going to skip that so we have some time for some questions. And I'm going to finish by just thanking our funder, the Alberta Ministry of Labour, and our key collaborators in Alberta Health Services, that's Carol Chambers, and Fairview Health Services, Darcy Millard-Johnson, and then Susan Arnold and Hannah Cab down in Minnesota, George, who's here luckily, and I'm going to deflect all questions to George, Matty and Andrew, who you know well, and Melanie, who's also here from Victoria, and then Sana, who's our grad student, who's going to be doing all this future work. Thanks very much.
Thank you very much, Hugh, for this very nice overview of the work you've been doing along with others. So we do have 5 minutes to take questions, and I will be taking questions from the online audience as we're going. I actually do have a question, so I'm going to take advantage of my role here and go first. So it's really nice to see the natural progression of these studies and how they have evolved over time. But thinking about this kind of a history and the historic perspective, and thinking about how we have adopted cell phone use, and relating that to the work that I'm doing, where I'm looking at the role of microbiome in disease, and we have there's now evidence that shows that no need to go look for corners or mold or but look at cell phones. That's where those are the areas that are the most infected, where you see the largest amount of loading on it. Is this something that you're thinking about?
Well, it kind of follows on from my last comment. I think that if we can find indicator, like the canary in the coal mine, then that's ideal, right? So I think we have the kind of data set that would allow for that analysis, although we never thought of doing the cell phones. In fact, I'll mention this, another challenge that we had. We actually applied for ethics for this study and were turned down by the you don't need ethics for this, it's environmental sampling. So we said, okay. And we tried 3 times, 3 different agents. But part of that is we can't do anything which is linked to an individual. And one time well, this is borderline, it's not really an individual, but we got a pen. Someone wiped a pen and sent it in. We just analyzed it. And they said, oh, this pen was actually one of the most contaminated things we found. And so we told them, and of course, well, they didn't know which pen it was. So the choice was to get rid of every pen in the hospital or clean every pen in the hospital. We said, well, that's, so you're right. It's, there are things I'm sure we've missed. I never thought about cell phones.
Thank you very much. I agree. It was a very comprehensive program of research. It's nice to see from over time and depth and breadth. I guess I was, of all things, I was intrigued by the KT part of it, the knowledge translation, the decision to communicate results back. And I was intrigued by I guess what I was seeing as the report with all the data on it. And I just wondered if there was a conscious decision to make it a data-filled report versus a kind of key messaging, kind of this area in your unit versus all that data-driven.
Right.
I was interested in that element of it.
Yeah, I think because both the sites involved had previous monitoring done, I think there was an expectation that this would be the form that they would find it in. As I said, we did have a lot of discussion about the reporting. We couldn't start until we had all of that sorted out, and we decided on this. It's not entirely novel. It's certainly been used in other studies. In terms of reporting back over time, immediately, I think that was a conscious decision. We felt that we could, by documenting responses and modeling those, we could handle them as well as what would be the other obvious way is just to sort of not give them any feedback for a year and then give them the summary kind of. I think, I don't think it's in any way compromising the study design to have this information flow back, although part of the temporal variability that we're seeing may indicate that the process of feedback is altering exposure conditions, which would be wonderful. That in itself is a finding. And one of the reasons we want to bring additional sites in. So we're sort of on it, yeah, it was a conscious decision. Yeah. George, did you want to add anything to that?
Just that there's such a knowledgeable group.
Yes.
They were pretty motivated to do something, so they absolutely wanted results that was an implied condition of cooperation.
That's right. Yeah. So George was saying that all of our participants have been amazing. They are very informed. As I say, 2 of them have published on this themselves, just their findings from their sites, and they're already experimenting with different cleaning protocols. So they're really taking advantage of this as well, which is a great aspect of this study.
There's a quick question online. So this question is asking, and they go as people are asking. There's a lot of interest on this side. How can fentanyl clearance testing be done? Fentanyl.
Let me think about that for a second. I'm going to pass this one to George. The question was, how can fentanyl clearing be done? But I don't think it's not really part of our study, is my...
Fentanyl?
Yeah, I think that's outside of the scope of this project. I know that when I was reading up, I was mentioned there's some real-time assessment technology that's coming online. So for immunochemical tests, and one of those specifically came out of methamphetamine testing. So I don't know if that might be a lead for this person, but there are sort of real-time tests that first responders use where they can do a wipe test on surfaces to see if there's methamphetamine. So that might be okay. Actually, while you're passing that, I also should have said Avatar's work. I didn't see Avatar's work because Avatar's been working on this project as long as anybody, right? So another person that deserves recognition as well.
Yeah, just wondering if any work's been done to try and detect these antineoplastics in the body fluids of the people that are handling them, the pharmacy people and the nurses and so forth?
Yeah, for sure. So a lot of the early work, that's where this started, very much so. So looking for metabolites and the compounds themselves in urine, probably blood, is mostly urine, I think, the studies that have been done. The problem is that it's the kinds of study that they were doing, a lot of it was actually non-specifics. They were looking for mutagenicity of the urine itself. But a lot of the studies that were done were positive. But it's that kind of work has basically been supplanted by this environmental exposure assessment. But for sure it's been done, yeah.
Okay, we got a little carried
Yeah.
away with that. It's so interesting, I didn't even pay attention to time. So please join me in thanking Hugh for this work, and we hope to hear from you in the future.